let's go and learn about thin endometrium. It's a pretty complex topic, and this is what, in my practice of around, say now 22 years, we do get cases where we get endometrium like this. They're beautiful endometriums, and you can see here it's a triple layer endometrium, and it's beautiful, nice endometrium, bulging endometrium, lot of blood supply is there. We put a color Doppler and seen it. You can see that in case you look at this picture, the end of the blood supply is reaching the endometrial cavity. So it's a very, very nice endometrial cavity, and such are the endometriums we look for when you want to carry out any procedure, maybe spontaneous intercourse, maybe IUI, maybe IVF. These are the ones which we're looking for. And this is a delight for everyone. You can see a fantastic. Can someone out of you describe this endometrium? Anyone out of you? Anybody from IC? Quickly, 2 lines.
Sir, it is a triple line endometrium.
It is triple line mid cycle endometrium.
What
Mid cycle.
I've taught you one thing more.
It is good pre-ovulatory triple line endometrium under the influence of estrogen.
More.
Good cervical mucus.
Cervical mucus. Who was that?
Yeah, there is cervical mucus.
Yeah. Who was that? Who said cervical mucus?
Sir, Seema.
Seema, please send your.
Good morning, sir.
Please send your good morning, guys. Please send me your address. You'll get a chocolate.
Oh, thank you.
Lovely. So, guys, I've been guys and girls. I've been telling you that this thing is for the non-ICD people. Very simple. We focus here. I've always told you that ultrasound art is not looking at the endometrium only. It's looking at the cervix. Cervix is the one which is important for us. For a gynecologist, endometrium is important. For us, also very important. But for me, its journey starts from here. We climb up the ultrasound with our ultrasound probe. We climb up from here and keep moving up. In case this area is bad, we are dead. Normally we ignore it. So this is, today we're going to talk about this is very important, but don't ignore cervical mucus. Cervical mucus is a reflection. It is like a report of E2. It's a report of LH which comes in front of you. We can look at this and predict how much the E2 will be in the womb. And this both are correlated. So this we have covered in the class. So that's what I will tell you, that we have to move ahead of a triple layer endometrium now and look at the cervix and cervico-uterine junction. And I've spent around more than an hour in every class with every batch to talk about this junction. This is a key area for us. Just remember this. Fantastic. Look at this lovely picture. Again, it's a very, very nice picture, as you can see here. The triple layer endometrium, and here you can see very nice blood supply rubbing in, rushing in from here. You can see a lot of blood everywhere. It's a beautiful endometrium here. It's a triple layer endometrium. Good. Sometimes you get caught with such an endometrium. What to do here? This endometrium is a thin endometrium. This is a day 11 endometrium. Thin endometrium, 0.43, 0.43 endometrium. What to do here? It's a big challenge for us. Now, then again, we get an endometrium like this is a uterus, and this is again we get a thin endometrium. What to do here? So the challenges start increasing when you start getting such poor quality endometriums, and we don't know what to do. And these endometriums can vary from 4 to 6 millimeter or even 7 millimeter, and we are at a fix. Very routinely, we get patients from abroad who come down for their FETs or for their other procedures. Linings are not growing. Those people are staying in the country for months and years, but the lining becomes a big challenge. But when we say thin endometrium, sawal uthta hai, the question comes that what is a thin endometrium? How do we define a thin endometrium? So today, I'm going to talk to you about thin endometriums. What all I have not covered in the classes, the basic concept of curtain raiser is I don't cover in the classes is being taught here. So in the classes, we'll be teaching you the procedures, how to do PRP. We teach you how to put GCSF. We teach you how to do scratching. But those things we are teaching you. But we don't teach you much of theory in the classes because shortage of time. So today I'm going to go to the whole theoretical aspects, the academic aspects, and the guidelines. So that after 1 hour today, you should know what is right, what is wrong. And then we pick up the techniques as experimental or non-experimental. So thin ET, what is thin ET? Thin ET means any endometrium less than 6 millimeter or 7 millimeter or 8 millimeter. I don't have an answer, and neither many people have. So what we do is that we go through the literature and try to find out and remove this dilemma that is this endometrium thick or thin, to transfer or not to transfer, to do IUI or not to do an IUI. That is the thing which we have to learn finally. Thin endometrium may not affect us, but the outcome of the procedure is going to affect us. But there are multiple papers. Thin endometrium is everybody's delight. You press a button, so many papers roll out in front of you. So they say that any endometrium less than 7 millimeter in an FET cycle. When you want to do an FET cycle, frozen embryo transfer cycle, less than 7 millimeter is a thin endometrium. And when we talk about a fresh cycle, they say less than 8 millimeter is a thin endometrium. So for fresh, it is 8, and for FET, it is 7 millimeter. This is one definition I wanted to give to you so that you are aware that there is a cutoff for these things. Going from the dilemma of 6, 7, and 8, and 9, and 10, you should know that 7 and 8 is the cutoff laid down by many of these articles available to us. Now, again, a study by Avers, they said live birth rate is 20% in fresh when the ET is between 5 and 6 millimeter. And in FET, between 4 and 6 millimeter. Meaning that as the lining becomes thinner, the chance of our getting a pregnancy keeps becoming more difficult. This is what we have to understand. So before I start that topic, to get the whole team with me, a few pictures which I normally always show. We look at a thin endometrium. A thin endometrium is something like this. Thin endometrium is something like this. So when we combine these two, we get a thin endometrium. It is less than, say, 7 millimeter. I'm just taking a figure. The thin endometrium is a non-receptive endometrium. Now, this is a thick endometrium. A thick endometrium starts more than 7 millimeter, depending upon what type of case we are doing. But a good endometrium is always more than 8 millimeter. And I say, my experience, I draw a cutoff at 1 centimeter. This is the cutoff I draw it. But here they have gone to 12 millimeter also. This is a receptive endometrium. And then we know that every month the woman is going to bleed and her endometrium is going to be shed and rebuilt again. So when we talk about thin endometrium, what comes to your mind? How to do it? These are the things given. Somebody says take some nuts, somebody says take olive oil, somebody take they give you some herbs, fresh vegetables. They're all given in the books at multiple places. We use all these things and try to improve our endometrium. So these are a few pictures which are available on the internet in the articles which they say how to improve your thin endometrium. And very commonly they all talk about olive oil and avocados. Avocados and olive oils and broccoli are the ones which give you a thicker endometrium as per the books. Some books have written that do femoral artery. Try to palpate a femoral arteries. Put your fingers there and keep rubbing them. They will increase the blood supply. As you can see here, the blood supply after rubbing, in case we do it, the blood supply will increase. This is one of the concept. By doing femoral artery, pressing on the femoral artery, the pressure goes high. Pressure goes high, endometrium will build better. Well, that's the background of thin endometrium, and now I'm going to move ahead. But before, as I'm moving ahead, I'm going to write my number here. Kriti, you can also put the numbers in the group. A lot of people have joined us from outside. So put the numbers in the chat box. You can copy our numbers in case you want to contact us. Feel free to contact us anytime.
Yes, sir. Yes, sir.
Put the numbers in the chat box. So the majority of the methods to cure thin endometrium are empirical. And when I get tired, when I really get tired, many times my biggest issue is majority of my people who are coming to me, they are from abroad, and they are from either from the Europe, or they are from Asian countries, from Middle Asian countries. So the best medicines to work here when you fail is something called Ayurvedic. They work very well. If I tell you that in case you fail, do try Ayurveda. It works very well for thin endometrium. It's empirical. It won't cause any harm. But it's only when you fail, you start going to these things. So this in background, look at a triple layer endometrium. How does it look like? Triple layer endometrium means that when the two layers of the uterus come together and two fluffy layers meet, and then we get a central layer and it forms three layers. So it should be around 7 to 10 millimeter minimum. Ideal is 8 to 10 millimeter. So this is what we feel is right. For FET cycles, it should be 7 millimeter, and for fresh cycles, it is 8 millimeter. This is the data which we have. For IUI cycles, for ovulation induction cycles, the exact numbers are not given anywhere. I've gone through a lot of articles. They're all very ambiguous. So now, moving gradually, I'm going to build up my topic now. We spoke about the endometrium. We spoke about a triple layer endometrium on ultrasound. And we spoke about 7 to 9 millimeter endometrium. A big range which we have, at which the implantation can occur. We find that what's happening here is that the endometrium starts at 2 millimeter and it goes and touches around 1 centimeter. And then after 15 days, it will again become 2 millimeter. So endometrium will keep going in a circle. It will keep going in a circle like this. So as the endometrium becomes this thick, and I'm sure that all of my friends here, we spoke a lot about P4 and LH. So what builds up the endometrium? Does someone remember? What builds up the endometrium? And I need a single chocolate answer. Which hormone will finally build up the endometrium?
Estrogen.
No.
Estrogen and progesterone both.
FSH. FSH.
No. LH. Why? LH brings blood. LH brings VGF. LH will, when LH rises, that's the time blood supply will increase. Blood supply increases, endometrium will start like a glucose for it's like glucose for endometrium. Glucose for endometrium. It starts building up very quickly. So blood supply increases. The arteries become more spiral. Yes, estrogen is also important, but the progesterone also comes. But an hormone which builds up the endometrium is the one which will bring more blood. And more blood comes with E2 going high. E2 will bring VGF. And then there is surge of LH. That surge will prepare. See, when surge occurs, after how many hours of surge is egg ready? Anyone?
24 hours.
24 hours, Kavita. Fantastic. 24 hours. And the 24 hours, your egg is ready. And it ruptures by how much time? 36 hours.
36 hours.
And after how many days of 36 hours do we have implantation? Quickly, guys.
5 days.
5 days.
Fantastic. Day 5, we have the implantation. This means the whole game is of 7 days or not?
Yes.
Yes. Do you think that the body will keep the endometrium ready on its own with E2? No, it doesn't.
No, sir.
It waits for the LH to go high. See, body is very, very mean. Body will take out all the blood from the brain in a woman and put it in the endometrium. It only do it when the follicle is ready. And when is follicle ready? When E2 goes high. And that's the time when LH goes high, it has 7 days to prepare this. Are you with me? Any doubts? Shouldn't be any doubts. This is what happens. Then we have implantation on day 7. On day 7, we have implantation, and this implantation will occur on approximately day 5 of ovulation, or nearly day 7 of the LH surge. Approximately, that is the way it goes in the body. So we know that. Having said this much, we are aware that the most important prognostic factor for implantation is ET, endometrial thickness is what we. So EMT is the most important thing we have. In case endometrium is not appropriate, it means that there is lack of blood supply, there is lack of glycogen. Even if the E2 is normal in the body, LH is normal in the body, P4 is normal in the body, E2 can still be bad. This happens when the E2 is pathologically bad. Gentlemen, ladies, there are conditions like PCOS. In PCOD patients, again, will have thin endometrium. But here endometrium is fine, but endometrium is under effect of androgen. Androgens go very high.
Many follicles.
Yeah. So E2 is very high, testosterone is high, E2 is high. That also suppresses the endometrium. So endometrium can be pathologically bad. Oh, hey, kharab, do anything, it won't improve.
But
Or
sir, in PCOD, LH is also very high, no?
very high, exactly. LH is very high, but it is pathologically high, no? It is pathologically high. So for LH, what did I teach you in the classes? How much LH is required at the time of LH peak? Anyone? LH surge means how much LH?
So it goes up to 100, 120 also.
120. Fantastic. Maybe 200. So LH is the only hormone in the body which goes very high. See guys, E2 starts at around 50, and E2 starts at 50 picograms on day 2 and touches around 300. Okay. Are you with me? So 6
Yes,
times.
yes, yes.
LH starts at 4 and goes till
Yes.
200.
Yes.
LH will have to have a peak. Now, in case LH is present, LH should go like this and then fall down. This is a peak. In PCO patient, LH is already.
So your voice is cracking.
Yeah.
So your voice is not clear.
Sorry. COVID effect. I can blame it on everything. Can blame everything to COVID now. So LH doesn't go high, then follicle doesn't mature. In case LH goes like this in a PCO at high values, then the follicle won't mature. So there's a difference between LH being high in a normal
All the
body
time.
and LH being high all the time along with E2.
Yes.
और LH के दोस्त कौन होते हैं? LH के जो friends हैं, that is E2 and testosterone and androgens. When all the
Yes.
3 friends come together, they destroy the endometrium. So in PCO patients, your endometrium is fine.
Yes.
So to improve the endometrium, break the friendship. Break the friend. 3 naughty children in the class are getting cures. So in PCOS, what we do? Put all the 3 children into different classes, different sections, and endometrium will start growing. This is about how the endometrium get affected by the LH. Fantastic. So thank you so much for being connected. Assessment of endometrium is the most important thing, that we fully agree. Prognostic factor, thin endometrium, thick endometrium is the one which is important for us. Beautiful. So now we have got 308 participants till now and 309. Thank you so much for being with us, and you don't know how happy we feel. For me, ये मेरे लिए experiment with truth है. लोग कहते हैं संडे के दिन लोग आएंगे ही नहीं. Do anything, people won't come. I said my guys will come. They will definitely come. So I put all my bet into all of you, and you have never proven me wrong. A thin endometrium is less than 7 millimeter. Again, now look at this definition. This is the right definition. That definition, endometrial thickness doesn't have much of meaning, but it has to be seen on what day of the periods. Endometrial thickness less than 7 millimeter or 8 millimeter. I'm just saying some number is there. On the day of ovulation, after this means that LH peak has come, or on the day of HCG injection, when you're giving the peak to the person, or when we are doing starting progesterone. It means that when follicle is ready, that's the time endometrium is noted. Before that also we are noticing. But in case you want to say somebody has got in a PCO, somebody has got 5 follicles which are 14 millimeter. 5 and 6 follicles which are 15 millimeter on the other side. And endometrium is 5 millimeter. Hey, will you call it a thin endometrium? Anyone? Any of you?
Asynchronous.
No, sir.
Asynchronous.
So it can be an asynchronous endometrium, but not a thin endometrium, because we are seeing the reason. There's an endocrinological reason for endometrium to be thin here. But when we find in a woman follicles of 20 millimeter into 2, and we find that cervical mucus is present, and endometrium is 5 millimeter, then what do?
Thin
Thin
endometrium.
endometrium.
Fantastic. Defining is very important, guys. So now, I've always believed that we never talk the basic principle of our Pathshala. Our Pathshala, where you are my teachers, we are all each other teachers, is go by the evidence. No personal experiences are here. Evidence. And I want you all, in my classes, I don't give you any evidence. In the classes, I tell you what I say is the evidence, in case you remember. But today, in all, curtain raisers is only evidence. So evidence, quality of evidence is plus. This is a grad recommendation of Canadian guidelines. It says thin endometrium is less than 7 millimeter or 8 millimeter. 7 millimeter or 8 millimeter is thin endometrium. Thin endometrium is a thin endometrium. The incidence of thin endometrium in ovarian simulation cycles, that is for when we do IUI, when we give letrozole, clomiphene, and tamoxifen, it is around 38 to 66%. So remember 50% figure yaad karo. In IUI cycles, it can touch nearly 50%. In case we add HMG, it will become lesser. In IVF, 1.5%. These are few numbers. You have to know these. Please know these numbers by heart. Great. So here, before I move ahead, in case you ever get stuck, kabhi aap phas jate hain. You don't know what to do with your endometrium. It's not growing. You've tried everything. There is one drug which can work. Clomiphene won't work. Letrozole won't work. Clomiphene and HMG may not work. So what is the drug of choice in such cases? Anyone? But tamoxifen is a drug for cases. And tamoxifen, what are the dose? Quickly, dose.
Letrozole plus
Nitropins.
OIs. We're talking about OIs. We're talking about ocean induction. What is the dose of tamoxifen? Quickly.
20 milligram 1 BD.
20 milligram or 40 milligram or 5.
20 PD.
Yeah, fine. This 20 milligram, there are 6-7 papers are available. I'll be sending all papers to you. As customary, all papers will reach you. So 20 milligram or 40 milligram per 5 days. To this, you can add HMG also. This is a wonderful. How does tamoxifen work?
This causes the hyperplasia of
aromatase inhibitor.
Tamoxifen.
Letrozole is aromatase inhibitor.
Receptor modulator.
So
This has positive effect
receptor
peripherally
modulator.
on the endometrium, causes the hyperplasia of endometrium. And centrally, it is same just like CC.
fantastic. Who said that? Very
Dr.
nice.
Neena Gupta.
Dr. Neena, fantastic. Who's going to tell me how does coffee work?
Pardon, sir?
How does coffee work?
Coffee.
Centrally stimulating.
How? कुछ तो नई चीज सीखेंगे ना आज. What is adenosine? When you get up in the morning, there's a molecule called adenosine. It is released. हमें सुलाता क्या है? What puts us to sleep?
Melatonin.
What wakes us up? Adenosine.
Serotonin.
Adenosine. Adenosine gives us energy in the morning. Some people like me wake up grumpy all the time because I sleep at 11, get up at 3 o'clock in the morning. कहते हैं बुढ़ापा आ गया so नींद ही कम आती है. But anyone, it's adenosine. Wakes you up. Adenosine gives you activity. Fine. जब तक body में adenosine है, you are active. Adenosine levels will start slumping down by midday. Then you start feeling tired. Adenosine works centrally. What does coffee do? Coffee will go and bind with the receptors of adenosine in the mind. As a result, adenosine is lying free in the body, energizing you. So we are drinking coffee, but what is working is adenosine. Adenosine. Fantastic. This is how it works like clomiphene. It works like tamoxifen. Remember coffee also. So this is the way it works. Now coming to few more lovely things we can see here. So in a fresh embryo cycle, 8 millimeter is the cutoff. Strong recommendation. It's very strong recommendation. In frozen IVF cycles, 7 millimeter is the cutoff. Strong recommendation. GRAD, GRAD. I've already taught you. Last class we had taught you GR grade. We have taught you recommendations. Am I right, Akriti? Quality. We have covered this chapter for them. We have covered for them.
Yes, sir. Yes, sir.
Now, if somebody has got a poor endometrial thickness, go for cryo-80. Preserve. Now, remember, what is a weak recommendation but a good recommendation? They have compared many protocols. They find that for thin endometrial, in ART, undergoing endometrial preparation for FET, there is insufficient evidence for natural cycle or hormonal replacement for endometrial preparation. So this is the evidence. It says there is a weak. Many people say, I will give 5 tablets of tamoxifen, then I will give HMG, then I will trigger, and day of triggering, after 7 days, I will carry out blast transfer. This is the induced transfer. Some people do natural transfers only. They don't give any hormones, but they all claim my results are better or that result is better. But the evidence says the Canadian guideline, that's the only article in the world which you can actually trust. That's the only article in the world presently which says that this is a weak evidence, though weak evidence, but there is nothing, there is insufficient evidence. This I want to tell you, there are no studies available that which technique is better. So somebody who talks to you talks out of their personal experience, which I normally avoid quoting personal experience. Incidence. Thin AT incidence kitna hai? I've told you. Now I'm building the topic backwards again. Thin endometrium is more common in the elderly people. As we age, endometrium will become thinner and incidence of 5% has been reported less than 40 years and 25% after 40 years. As the eggs are aging, the AFC is reducing. When the AFC is reducing, when the AMH is reducing, endometrial thickness is also reducing. Just remember. In ovulation induction for IUI cycles, it can be around 38 to 60%. I give you 50% ka number. And for IVF, between 1 and 2.5%. I've repeated the slide here deliberately. How do we measure the endometrium? Simple concept is that we measure by, we have this one, sagittal plane or longitudinal plane. So we take either longitudinal plane or sagittal plane, the thickest part of the endometrium near the fundus we take, and we record from the white line to white line. This is the way we record endometrial thickness. I've seen people, what they do is they put the probe inside and they start recording the endometrium at the thickest portion. All my friends here, can someone tell me what should be the right plane for recording the endometrial thickness?
Sagittal plane. Sagittal plane.
What more?
Mid-sagittal. Mid-sagittal.
Perfect. What more?
As a complete endometrium is visible from
Complete
1 centimeter below the
endometrium
fundus.
And the uterus should be
1
occupied
centimeter below the fundus.
Yes.
We should see the cervix portion of the
Whole the
endometrium.
Including
endometrium is visible till
cervix and
cervix.
uterus.
Cervix.
and uterus occupying 3/4 of the screen.
Perfectly fine. Gentlemen, ladies, again, cervix. Cervix. I want you to speak about cervix. I don't know why you're so angry with cervix. All of you hate cervix. I think so. No one talks about cervix. IVF is equal to cervix. In simple terms. Don't ignore cervix. So, endometrium is recorded. You take whole of the, that's the way it is recorded. In case you're not able to see the cervical mucus or the cervical plane, cervical sagittal plane, it is wrong recording. So this is wrong recording. This is the right recording because we are often recording day to here and now here. Beautiful. Okay. So please, whenever in IVF, climb up the cervix. विजेना में जब प्रोब जाता है तो सर्विक्स के साथ साथ ऊपर उठना है. अगर ये नहीं करेंगे, IUI तो कर पाएंगे आप. You can do IUIs, but IVF नहीं कर पाएंगे. This you have to understand. Yes, the English. Here comes the English. 1 centimeter of the frontal tip, mid-sagittal plane, EVS probe, blah blah blah. English is there. English is everywhere. But we don't talk about cervix. Something like, the cat didn't teach the lion to climb the tree. That's it. So cat is cat. This is what people don't teach. One more thing before I move ahead. Again, very important point I've covered in the class, but I'm reiterating it. That when you look at the endometrium, please be with me for next around 2 minutes. Look at the endometrium. This endometrium. You'll always find a area which is hypoechoic. What is hypoechoic area? What color is hypoechoic?
Endometrial junction.
black.
Black.
Yes.
Color is black.
Yes. So it is hypoechoic. Hypoechoic means black. What is that black area?
In between the endometrium, 3 layers. The white layer.
What is that black area?
Glands.
Okay, this is cavity.
Zone 3.
Uterine cavity.
Myometrial invasion.
Endometrial junction.
No.
Blood vessels.
Bacillus layer.
Yes.
Endometrial blood vessel.
Bacillus layer.
Vasculature.
It is the lower layer of the myometrium. The lower part of the lower part of the myometrium is black area is the myometrium.
Hypoechoic area of the junctional zone.
That is myometrium. That black area is never counted in the recording the endometrium. And what is that area? क्या होता है उसके अंदर? What artery? Basilar arteries. Basilar arteries are there. अभी फोटो दिखाता हूँ. Good. I've started the conversation, and that's what I only wanted. I've done the conversation. The black area around the white line of endometrium is myometrium. And that is the area it becomes black. Why does the area become black? Gentlemen, ladies. Or ladies and gentlemen.
So because of vascularity,
Fantastic. You are my driving force. I feel so happy that you are able to answer this question. Beautiful. So, summary statement. Abhi hum padhenge summary statement. What does summary statement tell us? By quality of evidence, grad quality of recommendation, they say various factors can limit the accuracy of endometrial measurement. What are these factors? Fibroids, adenomyosis, polyps, uterine orientation. So अगर आप, in case you don't look at the cervix, you have taken the wrong recording. Body habitus, if a lady who's slightly obese, you may have difficulty. Previous surgeries can give you a problem. Uterine contraction may be occurring that time, there can be a problem. Ultrasound machine quality can be a problem. Inter-observer and intra-observer observation and patient intolerance. They can all lead to poor quality recordings. Be careful. Okay. The endometrium, never forget this thing. Strong recommendation. Coffee, cappuccino, morning cappuccino is that transvaginal plane, thickest portion near the fundus. But it is a cat. It is not telling you how to climb the tree. Cat will say keeping the cervix in view. That's it. Without that, it will be incomplete. Repeating, suppose you get a thin endometrium. Should I call somebody else to do it? Should I call, can I call Sandhya? Sandhya is very quiet today. Sandhya, what happened? Why is Tirupati Sandhya? She's very quiet today.
Good morning, sir.
Good morning, Sandhya. You just came on the screen. So you have to just remember that the endometrium, it's a weak recommendation, but it should be repeated. Because I get a bad endometrium, I do call my colleagues to do it. That's a patient is important. Uterine cavity assessment, we always do by hysteroscopy. Sonohysterogram, yes, you can do, but my favorite is hysteroscopy in case I'm getting persistently thin endometrium. Done? Now look at this endometrium. Endometrium is recorded. Look at this now. Here I'm recording this endometrium. So this is a white line to white line, good endometrium. In case you get a fluid in this cavity, then we record here and we record here.
So your screen is not moving.
No, I'm not moved my screen. Not moving. Can you see the ultrasound film on the?
Yeah, ultrasound
Yes,
film.
No, sir.
No?
yes.
Not
Scan.
able to see your screen, sir.
Is it moving now? Layers of endometrium?
Yes.
Yes.
Yes, sir. We can see, sir.
It is outer
You
to
can, sir, you can just, sir, a काम करें आप video बंद कर दीजिए 2 मिनट के लिए. Then probably it will bounce back. Or you log in again. So in case we have the fluid filled cavity, then we ignore the fluid and take it from here to here and record it. Add 1 + 2. Don't count fluid in this. So I've told you, but always counted with cervix in view. My dear friends, cervix is cervix. See, uterus does so much of work in making a baby. It works so hard. But finally, who delivers a baby? Not uterus, cervix.
Cervix.
Remember one thing, a woman's journey for anything, it is cervix. Cervix is the main cause of all the problems or good things happening to a woman.